Thank you for the opportunity to talk today to you about recent advances in the treatment of ovarian cancer. Talking to survivors is one of my favorite things to do because these are the people that we're really trying to help with our research. Most patients respond to chemo and surgery who are diagnosed with advanced ovarian cancer, and they'll be in remission for some period of time. But unfortunately, most patients eventually do recur. About 20% of patients, though, don't even respond to initial treatment. And this is what we call an unmet clinical need, in that we don't have good therapies for these patients and they're not targeted by clinical trials. And I think we really need to correct that. So there's some critical questions we have right now for improving ovarian cancer treatment that are listed here. First is, can we prolong remission or turn a temporary remission into a permanent cure in newly diagnosed women? In other words, most patients do very well with their treatment. And can we turn that initial excellent response into a long-term cure? If patients develop platinum-resistant recurrent ovarian cancer, can we develop more effective therapies for that subset of women? And how should we best treat rare subtypes of ovarian cancer, such as low-grade serous, clear cell, or small cell? And how do we create effective immunotherapy for ovarian cancer? And finally, how can we improve treatment for patients who don't respond to initial chemotherapy, as I mentioned just now? The types of therapy for ovarian cancer can be separated into a number of categories, and I'm going to touch on each one of these in my talk: chemotherapy, targeted therapy, and immunotherapy. And I'll explain more about each one. You'll also hear the term personalized medicine. Personalized medicine means we identify particular characteristics of a cancer that help us identify the best treatment for that individual cancer, as opposed to treating all people similarly. So how do we identify the best therapy for an individual cancer if we want to follow personalized therapy? We can use histology, and that is important because ovarian cancer is really not one monolith disease. It's really a number of different diseases, as shown here on the right. Mucinous invasive ovarian cancer, endometrioid, clear cell, and high-grade serous, as well as low-grade serous, are all different cancers that probably arise from different cells in the body and follow different biologic pathways. And we should treat them all individually. So tumor sequencing is another thing that's commonly used. Everyone with ovarian cancer who has advanced disease should have this done at least one time, one time during their treatment. But it really does not help to sequence the same cancer more than once. We can identify therapeutic vulnerabilities from sequencing the cancer, but it's not going to change if we sequence that cancer 1 or 2 years later. We don't find new treatments for that cancer. There are experimental methods such as organoid testing for drug sensitivity, where you take the tumor, take fresh tumor in a special way, and then test it against different drugs. That's another thing we're looking at right now. First, to start with new advances in chemotherapy. HIPEC stands for heated intraperitoneal extracorporeal chemotherapy. And there's been a lot of interest in HIPEC recently, based on some data I'll show you in a second. So HIPEC is at the time of surgery, after all the disease or almost all the disease has been removed, very hot chemotherapy is pumped into the patient's abdomen and circulated. And that chemotherapy is at 104 degrees. And this adds a couple of hours to the surgical process. And it's actually a therapy that's associated with quite a lot of toxicity. So the reason there's interest in this is that in 2018, there was a relatively small study of HIPEC in the primary treatment of stage 3 ovarian cancer who were receiving neoadjuvant chemotherapy. In other words, people who were getting chemotherapy before their surgery. 245 patients got 3 cycles of chemotherapy and then had surgery plus or minus HIPEC, and then got 3 more cycles of chemotherapy afterwards. So half those patients got HIPEC, so about 120 patients. There was a 4-month benefit for time to recurrence, but nearly a 12-month benefit for overall survival. And that was enough to get a number of people just offering HIPEC in their cancer centers, even though most changes in upfront treatment have been based on clinical trials with thousands of patients. And in this study, only 120 patients got HIPEC. In 2021, just this year, there was a phase 2 clinical trial of 98 patients from Memorial Sloan Kettering who had recurrent disease, and they were undergoing secondary debulking surgery, randomized to the standard chemo plus or minus HIPEC. The patients who had HIPEC had a shorter time to progression of 12.3 months versus 15.7 months. In other words, they recurred earlier and did more poorly than the patients in the standard chemotherapy arm. So most of the time, we don't take things into the front line for patients with ovarian cancer unless they've been effective in the recurrent setting. And this makes us really pause about HIPEC, but there's going to be a large trial coming forward, I think, which will help answer this question. But right now, the frontline use of HIPEC really requires further exploration. And I would say that it's not ready for prime time, and it shouldn't be used outside of a clinical trial, except in the scenario of mucinous ovarian cancer, which is a rare subset of ovarian cancer. So let's move on to targeted therapies. Targeted therapies are drugs that are designed to impact certain pathways in the cancer cell or the surrounding cells. So this is a diagram that's supposed to represent a cancer cell, with the cell membrane up here represented by the double line of orange dots. And here's the nucleus, and here's the cytoplasm. And this just shows you a couple of the pathways and how signaling happens from the cell surface through multiple different proteins and can affect elements in the nucleus. And these are different drugs that affect different parts of one particular pathway. And there are many, many pathways that are like this, and there are many, many drugs that affect each pathway. So how do we know which pathways a cancer will be vulnerable to targeting? So the targeted therapies that are FDA approved in ovarian cancer treatment are Bevacizumab, also the brand name is Avastin, which targets angiogenesis. Angiogenesis is the cancer's ability to generate a new blood supply for itself. PARP inhibitors are another agent that you may have heard about, and it targets DNA repair. And some of there's 3 different drugs that are approved that are PARP inhibitors, and they're listed here: olaparib, niraparib, and rucaparib. There's many, many more targeted therapies that are in clinical development that treat specific subsets of ovarian cancer more effectively, and some that may overcome treatment resistance. So just to mention angiogenesis, since that's commonly used and approved in ovarian cancer. Judah Folkman was a pediatric surgeon who identified this process in the body, where a tumor creates new blood vessels in order to feed itself, and also they can use those blood vessels then to metastasize. And these are some of the factors involved in angiogenesis that are targeted by different drugs. So Bevacizumab is a drug that we use for maintenance therapy. Some of you, again, may know it as Avastin. So Bev maintenance improves the time to recurrence in the frontline setting by about 3.5 months. So if you do all your chemotherapy and you take it with the Bevacizumab, and then you continue the Bevacizumab for 12 months, it improves the time to progression for about 3.5 months, but it has no impact on overall survival, which is often, what's most important to patients. So that 12 extra months of therapy means coming in every 3 weeks and having infusion, some toxicity, an additional $100,000 in cost. So this was first published in 2011. Because of the small improvement in progression-free survival, the FDA did not initially approve it, but they did finally approve it for frontline maintenance in June of 2018. So this really kind of remains controversial, whether or not to use it in the frontline. And there are certain patients who probably derive more benefit from it than others. And those are the patients that we typically try to utilize this in the upfront setting. But in the recurrent setting, there's no doubt that Bevacizumab is a very important agent to add to standard chemotherapy in the recurrent setting, both in patients with platinum-sensitive disease and platinum-recurrent disease. So while its use is debated in frontline therapy, it's clearly advantageous to use it in the recurrent setting. And it can be used as maintenance in platinum-sensitive ovarian cancer. That means after completion of chemotherapy, or it can be combined with chemotherapy in platinum-resistant ovarian cancer. It also can be combined with a PARP inhibitor in maintenance therapy upfront or recurrent. And even if someone progresses on Bev, it's useful to add it again in the next regimen if they recur, which is different than other treatments that we use. Usually when a patient progresses, then we drop that treatment entirely. So another pathway that's targeted by targeted agents is DNA repair. So DNA repair is a critical function in cell survival and replication. There are a lot of things that cause damage to the DNA in cells, and including external factors and internal factors. But one of them is chemotherapy does cause damage to DNA, and that's one way that it kills cancer cells. Homologous recombination is one of the pathways to repair DNA, and it's really the best way to repair breaks that occur in both strands of the DNA. And cancers that have defects in homologous recombination are more sensitive to some types of therapy. So there's many genes in this homologous recombination DNA repair pathway that increase the risk of getting breast and ovarian cancer. So you may have heard of BRCA1 and BRCA2. They're in this pathway. Cells that are defective in BRCA1 or BRCA2 are more sensitive to radiation, some types of chemo, including platinum, and to PARP inhibitors. Several genes in this family have been implicated in breast and ovarian cancer risk as well. PARP inhibitors kill cells with defects in BRCA1 and BRCA2 and the other cancer cells that have defects in homologous recombination. And we call that synthetic lethality. If a cancer is defective in homologous recombination, it's more sensitive to the PARP inhibitor. So how many advanced ovarian cancers have BRCA1 or BRCA2 mutations? So there's two ways that a cancer can have a BRCA1 or BRCA2 mutation. The first is if the patient has an inherited mutation. So most women with ovarian cancer have had genetic testing in order to identify if they have inherited mutations in BRCA1 or BRCA2 and some other genes. If you take all patients with ovarian cancer, about 15% will have a germline, that means an inherited mutation in one of these two genes. But another 6% of patients will have a mutation in the tumor that's not inherited. In other words, the cancer has it, but it's not in their DNA that they got from their mother or their father. It's just a mutation that happened in the cancer. And those cancers will not be identified by germline genetic testing. They'll only be identified if you have tumor sequencing. And it's really important to identify the patients that have tumor mutations in BRCA1 or BRCA2 because PARP inhibitors are a very effective therapy for that. And these are data showing that in the upfront setting, so that means patients newly diagnosed with advanced disease completed their chemotherapy and had a good response to chemotherapy. They then went on PARP inhibitor, which is shown here in the blue line, or they had placebo, which is shown here in the red line. And this is the percentage of patients that are disease-free. So as you go down here, more patients have recurred. And this line on the x-axis is months since they went on the trial. So they're starting here at 100% disease-free at the time they start their trial. And then if they progress, if their cancer grows back, then they fall down on this line. And what you can see here is that patients did olaparib PARP inhibitor therapy for 2 years on this trial, and then they were done. And the patients who got PARP inhibitor did much, much better. So that even a few years after stopping the PARP inhibitor, they were doing much better than the patients that just got placebo. And so less than half of the patients had recurred at 4.5 years after completing therapy, after completing their chemotherapy, whereas only about 15% of the patients who were getting placebo were disease-free. So that led to their approval of olaparib by the FDA and European agencies for frontline maintenance therapy of women that have inherited mutations in BRCA1 or BRCA2, but also in patients who have cancers that have tumor mutations in these genes. And this shows that we really need to do tumor sequencing on everybody who has advanced ovarian cancer so we can give them a PARP inhibitor if that's indicated, because we certainly want people to be on this upper line as opposed to down here. So PARP efficacy is also evident for patients that don't have BRCA mutations, particularly patients that have other types of homologous recombination deficiency. And niraparib is approved for patients post-frontline chemo who respond to their chemotherapy. Patients had surgery and the chemo, and they took the drug in this trial for 3 years after they completed chemo. So not 2, but 3 years. And this is to show that PARP inhibitors do have side effects. More than half of the patients had nausea, 2/3 of patients had anemia, 1/3 of patients complained of fatigue, and almost half of them had low platelets. So for patients who had BRCA mutations, they more than doubled their time to progression of disease if they took the PARP inhibitor. So there's no doubt that we want to give a PARP inhibitor to patients with BRCA mutations, either inherited or in the tumor. But for patients without BRCA mutations, but they had HRD in the tumor, they still had an improvement of about 11 months, or they doubled their time to recurrence. And so that's still quite an effective therapy in that subset of cases. But for patients without BRCA mutations and no evidence of the HRD, they gained less than 3 months of benefit, which is less really than we see with bevacizumab. But most people would say that these drugs have more toxicities for the patients. So the FDA approved the drug for all women with ovarian cancer who respond to frontline chemotherapy, but patients do get different amounts of benefit from the PARP inhibitor. And whether or not it's worth it to take this drug with the attendant side effects for a minimal increase in response in this group of patients, I think is debatable. So now I'm going to move on and talk about immunotherapy. So immunotherapy, we're going to talk about drugs, vaccines, and cells. So immunotherapy means using some kind of treatment to boost the immune system of the patient to fight their cancer cells. So cancers are really well known for co-opting the cellular brakes that are used to control a normal immune response. And there's a class of drugs called immune checkpoint inhibitors that take the brakes off. So it's not that they're stimulating the immune system as opposed to removing the brakes, which allows the immune system to roll and to fight the cancer. That's because of that stimulated immune system, the serious side effects of the immune checkpoint inhibitors consist of autoimmune type side effects. In other words, your body not only fights the cancer, but starts to cause inflammation in your normal tissues as well. So immune checkpoint inhibitors, the common ones are PD-1 and PD-L1 inhibitors. They're really not effective when used alone for primary or recurrent ovarian cancer. So many patients have heard of these drugs and want to receive them, but response rates are only 10 to 15%, and it hasn't been shown to help patients either in the primary setting or the current setting, and now thousands of patients have been treated. The combination of 2 different immune checkpoint inhibitors, a PD-1 inhibitor and a CTLA-4 inhibitor, has higher response rate, but much greater toxicity. And this combination is being explored, but again, it's kind of limited by the toxicity that patients experience. So there's many other drug-based immunotherapies that are being tested alone or in combination with the PD-1, PD-L1 inhibitors. So I think you're going to hear more about if we can develop more effective combinations. But right now, we don't have an effective drug-based immunotherapy for ovarian cancer. So the next thing we're going to talk about is vaccines. So we often think about vaccines as ways to prevent disease, but there is also a category called therapeutic vaccines, where we immunize the patient with tumor-specific antigen to augment the immune response to cancer cells. Because the cancers themselves tend to be immunosuppressive and dampen the immune response in patients, when patients are very sick is probably not the most effective time to use a therapeutic vaccine. And it's thought that maybe the best time point for vaccination would be when the patient was in their first remission. There were 2 large phase 3 trials of an anti-CA125 vaccine during first remission for patients, and both of these trials ended up being negative, which was very disappointing. Other vaccines in ovarian cancer have been mostly ineffective as well. There's another class, in addition to injecting a protein or something similar to that to augment an immune response, there's another approach, which is to use dendritic cells. These are cells that normally present the antigen in the cell and can in the body and can trigger an immune response. And they can be used as a type of cellular vaccine. So these types of cells can be taken out of a patient. They can be primed with the tumor antigen and then put back into the patient from which they came. So they're individual vaccines. They're not ones that you take off the shelf. And these are being evaluated, and both by themselves and in combination with immune checkpoint blockade. So then there's another class of immunotherapy that's called cellular or adoptive cellular therapy. Sorry. So these are, again, are patient specific. Cellular therapies are patient specific. They usually require leukapheresis, where you take out a whole bunch of blood. You separate the white cells. You give the patient back their red cells. And then they're stimulated in the lab to be more abundant or more effective. There's a number of categories of cellular therapies, including TILs, which stands for tumor infiltrating T cells, CAR T and TCR cells, and natural killer cells are newly being explored. CAR T has been a lot in the press, so you may have heard of that. And there's a little picture on the right how that works. So cells are taken out of the patient. Their gene therapy is used to put in a chimeric antigen receptor into that T cell. It's grown up in addition, expanded. That receptor is specific for the patient's cancer and will help the immune cell target to the cancer and to try to kill those cancer cells. Then they're injected into the patient, and then hopefully they go and attack the cancer cell. So there's a lot of interest in CAR T, and there's many companies that have sprung up. There's not yet an effective CAR T, but these are in clinical trials in ovarian cancer and many other cancers. All these cellular therapies require lymphodepleting chemotherapy to overcome immunosuppressive mechanisms. In other words, you get some chemotherapy to lower the immune response before the cells are given back, or the cells would just be killed by your own immune system. So these therapies are complicated. They can have very significant toxicities, and you often are given in a hospital setting or with very close monitoring. So I hope I've been able to tell you that progress is being made. I've been in practice for more than 20 years, and progress in the first decade was really incremental. But progress right now is happening very, very quickly. And another thing I think that's important to bring up is that when we talk about 10-year survival rates, they're always 10 years out of date. We're reflecting therapies that patients were being given 10 or more years ago. And treatment is changing so quickly right now that we can't really project accurately what 10-year survival is using our current treatments. So I really want to thank you for your attention, for your support of cancer research, and I want to express my deepest gratitude to all the patients and their families and loved ones who have participated in research studies and clinical trials that allow us to improve outcomes for women with gynecologic cancer.